Good evening and warm regards from East Kolkata Doctors Group. In this series of vlogs, which we intend to bring you every week or even every month, today we have a very interesting discussion to take place on COPD, which is Chronic Obstructive Pulmonary Disease, a lung disease. And who better to take us through this than Dr. Sumit Sengupta, an experienced and senior consultant in respiratory medicine. He trained in the United Kingdom and has been in India for few years now and has brought a lot of enlightenment to the world of respiratory medicine, not only in Kolkata, but across the state of West Bengal as well as across India. Dr. Sengupta, warm welcome from EKDG. Warm welcome to this vlog.
Thank you, Dr. Sinha, and thank you for inviting me. And I hope I'll be able to sort of answer your questions. And I certainly think that COPD is an important and common enough disease which requires discussion at various levels, at the level of patients, patients' relatives, doctors, primary care doctors, specialists, everybody.
So that is probably the reason behind having a World COPD Day. But what exactly is COPD?
You see, when we breathe out, we have almost 80 square meters of, let's say, pipes in the lung, bronchi, bronchioles, trachea, which help us channel the air in and out. Every second we are breathing in and out. Now, these channels, when they get obstructed, you have obstruction. So that's where the COPD-O comes in. And when it's chronic, as in it's long term, over a period of months to years, we call it chronic obstruction. Now, just apart from the descriptive term, COPD now essentially means these obstruction is due to mainly three conditions or three, let's say, situations. One to eight is cigarette smoking. Number nine is if you worked in coal mines, that is luckily becoming very rare nowadays. Number 10 is something we don't see much of, but it is there in the rural areas where biomass fuel used to be coal, and now it's wood and sort of cow dung, and with those are burnt. Basically, all of these are inhalation of particulate matter. In case of cigarette smoking, it's not the nicotine which makes you addicted, which damages the lung. It's the all the other stuff. I believe there are more than 200 such particular matters in a cigarette and bidi, and coal obviously, and of course coal fires and wood fires, all of them. Apart from this, if you want to be pedantic, there are other causes which are slightly more esoteric and debatable, but in a nutshell, these are the three causes. So essentially, you see, you should not have any COPD. All these three things are preventable. You do not have to have any coal or biomass fuel cooking. You should not be working in coal mines without adequate protective gear, and you should not be smoking. So, effectively, 99% of all COPD is preventable, and in theory, with time, this is going to happen. However, it hasn't happened yet. It's one of the commonest diseases known to mankind, and it's probably the commonest lung disease, respiratory disease we have now.
So, in a given day, say of the first 10 patients that you would be seeing in a day, how many would actually in a respiratory clinic, which is you have run a specialized clinic, how many of these people would be having COPD of the first 10 people that you see in a COPD clinic?
Probably to the range of four or five. So
Four or
about half the patients I see. You see, it's the thing about COPD is they will keep coming back because
five.
it's not something we can fix with something. So we need to monitor and treat a bit like diabetes or high blood pressure, slightly more of a difficult proposition. But so it's a chronic disease. So once you diagnose, it's not like say a pneumonia where 2-3 weeks down the line we say okay, you're fine, you can go home. It's not like that. So we need to they keep coming back, and so we accumulate patients, we see new patients, and then it's there. So I would say about to ballpark figure about 50%.
50% of your workload would involve COPD.
Yeah, yeah.
So, what complaints do people with COPD have? What do they actually complain of?
This is a very important question. See, once you start getting symptoms, your lung capacity is near about 50% of where it should be. We have much more extra capacity in the lungs than we need. unless of course you're a marathon runner or something like that. So by the time the disease uh, destroys or decreases your lung capacity to about 50%, that's when a usual activity you will start feeling breathless, walking upstairs, maybe carrying something slightly uphill, or carrying something back from the bazaar, or running behind auto or a tram or a train. But before that, the disease is still there. It is there all the time. It's slowly progressive. But since we don't use the extra capacity, we do not understand that you have the disease. You do understand because during episodes of viral upper respiratory or lower respiratory infections, which is one of the commonest diseases known to man, then you become wheezy. Wheeze is the thing. It's a musical sound, ooh, ooh, like that. And if you've heard it, you know what it is. And so basically, slow decrease in the lung capacity, obstruction of your airflows, and as long as you're being sort of within an, let's say, a usual activity frame, by the time you have symptoms, you've lost approximately 50% of your lung capacity. So that is the worry, which is why we tend to do a risk assessment and say, let's screen for COPD. You may well have it, and that's the
So
thing.
let me just interrupt you here for a second, and we will come to screening. But say in the past it used to be said that chronic expectoration of sputum or a chronic cough was something that you found in COPD. Is that still the case?
Yes, but it's a to put it into sort of medical jingo terms, it's one phenotype only. Some people will cough up a lot, and you have this morning smoker's cough. You've heard this term before. Oh, I've got a smoker's cough. I cough every day. So daily cough with a little bit of phlegm being expectorated, that happens in a minority of patients, not
Right.
in most of them. And if they have that, uh, some of them will turn up early. Others tend to say, oh, it's a smoker's cough. All the smokers get it and they will not seek medical help. That is the worry. At that stage, when before you are breathless, you need assessment of your lung capacity, but more importantly, you need to get counseling, help, medications to stop smoking or stop any other sort of exposure which might be causing it.
So not everybody will be able to reach Sumit Sengupta for a consultation or have an assessment. So for our general practicing colleagues or for our even our internist friends, um, how does one assess? You said screening, and I think that's probably the single most important thing one can do. How does one assess? Say somebody's come with shortness of breath, and I know I'm going into a very broad area where we need to do a lot of tests, but when does one suspect COPD and what does one do to try and prove that?
Right. I think, I mean, I see patients who come with shortness of breath. Some of them have heart disease, some have lung disease, some have something
Absolutely.
else. Uh, Very targeted questioning, keeping in mind that COPD is one of the
Is
commonest
there any
diseases.
score?
Sorry?
Is there any score that you can use to kind of
Well, what we look at is first the risk factor smoking, and we pin down the patient to the numbers, the age they started, not the average numbers, the peak numbers, and how many years. We call it pack years. So 20 cigarettes a day for 1 year is one pack year. If you're more than 10, you're likely to get COPD, 10 pack years, ever, ever, even if you've stopped 10 years ago. And if you're more than 20, you're very likely to get COPD, but that's only a probabilistic thing. So there are some smokers who get away with smoking. It's basically, so smoking history has to be pinned down, not a casual "are you a smoker" question. Number two is any wheeze during respiratory. Everybody gets viral respiratory tract infections 4 times a year on an average. Everybody doesn't get wheeze. If you're wheezy, you have either COPD or asthma. That's the working rule. So anybody with any wheeze, or you have heard some wheeze on the chest, you need to specifically look for COPD or other illnesses which may mimic COPD. So it's because we do it all the time. But for an internist, there are other things to screen for as well. But these are the three things. Yeah. How much have you smoked? When did you start? When did you stop? How many maximum? What's the ballpark figure? Do you get wheezy? Have you ever been wheezy? And put a stator on the chest. Yeah, a couple of wheezes when you breathe out hard. So let's look at this. So that's the standard thing.
So essentially, we come back to that same old thing: smoking, 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 smoking. So that is one thing I think which is a very important message that I think you're giving out today. And I think it's very important not only for our medical colleagues to take off, but also for people who are watching, lay public, who would want to know more about COPD, that smoking harms, it will continue to harm, and you must try and stop. So if the lung is already damaged by smoking, is it any point stopping anymore?
Yes, you see, it's a ongoing continuum of damage. Now, suppose you're sliding down a 45-degree slope. That's you smoking. Your lung damage is going down. Your lung capacity is going down and down and down. Now you stop smoking, the slope, instead of being 45 degrees, becomes 60 degrees. So you still deteriorate, because everybody deteriorates in their lung and other capacities as you grow older, but the slope is less. So it used to be, I mean, for the academically inclined, it's the Peto curve. This was explained that you actually change the slope of your lung capacity going down if you stop smoking. Now that slope depends on two things. We used to be taught by our teachers that all diseases are explained by the postulate of a loaded gun. The genes load the gun and the environment pulls the trigger. Now if it's a hair trigger, that means that any environmental change, even with minimal genetic predisposition, can cause COPD. COPD is somewhat in the range of more environment, less genetic, but there is a genetic component. Some people do get away with smoking a lot of cigarettes without having that much damage during their lifetime. So essentially what you're doing is, uh, the the people you mentioned who start getting daily cough, they're at high risk of having COPD, so they need to be screened. People who get wheezy with ordinary um, viral respiratory tract infection, they need to be screened, and it's very easy to screen. You just need to just write one or two tests, and that sorts it out. And if you are at risk, the important thing is to counsel people to stop smoking. If they have the disease already, as you pick up on the screening, it is a huge psychological thing to be able to say, look, you've already started the disease, you're going to damage your lungs further, and this is unfortunately irreversible. The damage doesn't get reverted completely, so you need to stop now. So it's very important that sort of way. Whether you need to treat everybody in the absence of symptoms, that is contentious, but again, that's a lot of patients we are treating nowadays much earlier than we used to.
So we are making some progress, because I think if you're treating people earlier, it means that the awareness is improved not only among the lay public but amongst physicians and internists as well. But I will stick to the smoking point for a little while longer, if that's all right with you. So, how does one quit smoking? What ways can you help someone stop smoking?
This has been very well worked out scientifically. In most cases, where up to 20 cigarettes a day are smoked by people, you see, when you smoke, the nicotine is what gives you the kick, and you are addicted to it. Like in any addiction, the nicotine sticks in your system for about 1 to 1.5 hours. Okay, so an addict will smoke on approximately 20 cigarettes a day, giving and they wake up and have a cigarette, because then the body asks for it. So you can make out whether the patient is addicted. It can be a physical addiction, but it is mostly psychological. And there are replacement things, chewing gum, all sorts of things. There are medications to do it, but the first important thing is for people to want to give up smoking. If they don't, no medication, nothing will help them. Oh, I'll smoke, my grandfather used to smoke till he died in 90. So that attitude, they will be having the nicotine gum and the patches along with cigarettes, huh? And behavioral changes can be done. You need proper planning and smoking counseling, cessation counseling properly. There is a protocol in which everybody is given a date. For 14 days, you take a pill which helps you to give up smoking. On day 15, you stop. On the day before that, you put a patch on which will mimic the effects of nicotine all through the day. And you have SOS nicotine gum in your pockets. Everybody in the family and the friends in the locality are told, he's giving us smoke, please do not come near him while you're smoking or smelling of smoke, or with a packet of cigarettes or thing. So it's a socio-cultural, behavioral thing, as well as pharmacological. If you the statistics are in this sort of counseling and medication use, 50% people have given up smoking at 1 year,
Mm.
which would be about 10 to 15% if you did not do all these pharmacological and counseling things. So people can give up without anything, just stop it after counseling, obviously. But so that's a 4 or 5 times more efficacy at 1 year than things. So that's good. If you get
Mhm.
every second person to give up smoking, that's huge. That's huge.
Fantastic. So, on that note, may I just stop here for a second and just tell our audience that you can ask your questions. There's a chat room where you can easily type your questions, and you have an expert here who can really address all your problems. So, whether you're a doctor or whether you're not a doctor, please feel free to type your questions. Any question is a good question, and we'd love to entertain that. So, Dr. Sengupta, moving on from this part of the discussion to now, where I'd ask you, you said 2 or 3 simple tests to make a diagnosis of
Right.
COPD.
See, one of the things which we measure is, as I was describing, these pipes which bear the air from the lungs outside and in and out and in and out. Those are called the airways. There are various technical terms, as you know, bronchi, bronchioles, trachea, and everything. So we measure how fast a patient can blow through that and how much air they can get out of the lung. We put it against a sort of normal values we would expect for that race, that height, that age, and we try and say, okay, this is 80% of predicted. Prediction equations are there; they are inbuilt into the thing. So it's called a spirometry, a simple test. A PFT is slightly more song and dance version of that, where you have other tests as well. But a spirometry is done everywhere, and if properly done, it can show COPD very simply at a very, very, very limited cost. So that's one thing. The other things which we do are more advanced. We do something called DLCO, which is gas transfer, which looks at the amount your oxygen goes in and out of your lung, which also measures the lung damage from smoking and COPD. And also, we do something called a functional test, which basically says, how breathless are you? You're breathless. Who said so? How much? So we do something called a 6-minute walk test, which is more or less standardized. And we look at what happens to your oxygen, your heart rate, and how much you can walk in a specified 6-minute time. So these are not very, very esoteric tests. And at least PFT inspire 6-minute walk test, and in most cases DLCO can be done in almost any standard lab in the city. Um, However, it is a bit technician dependent. So they have to go to running places where they know how to get these. These are effort dependent tests. So as you know, effort dependent test depends on how the person conducting the tests explains and coaxes and cajoles or scolds the patient into doing proper tests, so that it's evaluable by the clinician. So that's an important bit as well.
I notice you don't mention chest x ray.
Chest X-ray. If the patient comes to me, I do a chest X-ray, because I'm not just thinking COPD, could be something else as well.
Sure.
But chest X-ray has a very poor sensitivity for diagnosing or ruling out COPD. So it will not diagnose or rule out COPD. In the very extreme, maybe 1 or 2% cases, we look at the X-ray and say, oh God, this guy's got COPD. But otherwise, they often look normal. So it's not a good test to diagnose or rule out COPD. We do it because obviously the patient doesn't come labeled as COPD. They've got a problem and we are sorting it out, and chest X-ray is part of our standard procedure to assess the lungs. So we look at that.
Okay, I think we've had a fair whack at finding out what is COPD, who are at risk, and how we can prevent it, and the tests that we can do, and how a physician will assess the patient to come to a diagnosis of COPD. So, how do we treat COPD? Is it very difficult?
um, it is at the same time very easy, and also extremely poorly, so let's say, subscribed treatment. To put it into perspective, when we started out in medical college almost 30, 40 years ago, we were scared of COPD patients. We would run away. We had only two injections. I'm sure you remember them, Decadron and Derifylin, to give to an acutely ill COPD patients, and we give them some oxygen via nasal cannula, and then we said, "Oh my God, let's run away. Let the next lot handle this patient. He's going to die." There's a dramatic change. There's a dramatic change unless the patient has come at a very late stage or for some reason is not responded to treatment, which is a smaller portion of patients. Then we can almost maintain a normal lung capacity in the people who have moderate level of disease and they've stopped smoking. Uh, this is because of inhalers. Inhalers are magic for COPD and for diseases like COPD, like asthma as well. And they get, and nowadays the variety of inhalers which help patients with COPD, uh, a lot of fine tuning needs to be done, so it's too vast to just mention like that. Two three things about inhalers needs to be done. This is a chronic disease, so you don't treat it when you have symptoms, you treat it all the time, like diabetes, like blood pressure. Okay, so some regular inhalers need to be taken. Inhaler technique of whatever device has been given to you is paramount. There's a 30-fold difference in amount of drug entering your lung depending on how well or how poorly you take your inhaler device. So every time you need to learn, you need to be reassessed and then retrained, otherwise it doesn't work. And of course then the choice of drugs, they keep changing, and we are now fantastically, we have every drug which is available in the world at much lower prices, I must add, than the Western countries. And I think we treat COPD, if they listen to us, much better than what he would do in the US or the UK.
Mhm.
Much better, much earlier, with much cheaper drugs, as long as the patient and the doctor are on the same page about it.
That's really really heartening to note. But I, from a non-respiratory physician working in a tertiary care hospital, often get to see patients with COPD admitted. Why do they get admitted?
Right. We talked about a slope, like lung capacity going down. There comes a sort of point of no return, and there's no number written on it. For each person, it is different. Nowadays, most people don't reach that slope, that point in the slope, sorry. Uh, at that stage you get recurrent, every viral infection, remember we said 4 times a year, that causes you to have lots of wheeze. Your inhalers, you take extras, they don't work. Initially you go to the outpatient, you get treated, it's called an exacerbation of COPD, and then the next time you're slightly worse than the last time, and it goes, it's a slippery slope. Once you reach that place, then it's a different ball game. But I must again reiterate that a much lesser number of people reach this situation because we are now picking them up earlier, getting them stopping smoking and giving them inhalers a lot earlier than we used to, and we are aggressively treating this. Once you reach this stage, it is not a good thing. Say for example, if you have respiratory failure during an acute attack or exacerbation of COPD, and you get admitted to hospital and you require what is now the gold standard non-invasive ventilation, or BiPAP it's commonly called, 50% patients are dead within 2 years for one index thing. So it is a extremely
Mm.
poor prognosis situation. But let me tell you that this is now decreasing day by day as the all our efforts are getting into place. However, this non-invasive ventilation has been a boon. These patients used to die within a year, almost all of them, because we didn't have anything to treat apart from these inhalers and in hospital nebulizers. But with non-invasive ventilation, we have patients who are being using it at home,
Mm.
or very ill patients who are using oxygen and these non-invasive ventilators. They give us a huge benefit when you come in very ill, and we don't have to put them on an invasive ventilator which has its own attendant problems. So non-invasive ventilation, like inhalers, has made life dramatically better for these advanced COPD patients. These are a group which I think are decreasing in numbers, as in proportion of patients with COPD who end up with that bad disease. So that is very heartening, but it is a bad situation once you reach that place.
Right. You mentioned viral infections. Of course, would you say that they can be prevented by avoiding air conditioning or by wearing
See,
OBs? And
viral infections can be 100% prevented. In theory, there are people with various sorts of immune disorders, babies who have no immunity to speak of. If they catch a virus, they die. And while they're waiting for bone marrow transplant, they are nursed in glass rooms where nobody's allowed to enter. All viral infections come from other people. In effect, respiratory viruses I'm talking about. So if you can prevent, as we did in COVID times, that the virus is entering our nose, and mainly our nose and our mouth, by wearing N95 mask, all respiratory viruses practically can be prevented. But that is impractical in the long term. Short term, yes, we are still wearing it occasionally in highly infectious patients, TB, MDR TB, we wear that, but that is not practical in the longer term. So we know how it comes into your system. We it is, I wouldn't say impossible. It is extremely unlikely that anybody will be able to prevent it by wearing masks all the time. However, we have, apart from COVID, which I'm not going into, hopefully we won't need to look into COVID very at any great length any further in our sort of discourse. We do have approximately 200 known viruses, which, just like COVID, every year changes a little bit. So that viral respiratory tract infections are the commonest disease known to mankind. Average 4 times a year, everybody in the world gets it. More when you're an infant, and more when you grow older, where the immunity hasn't formed, where the immunity is waning. So it is very easy to diagnose a viral respiratory tract infection. You don't need a doctor. You get nasal symptoms, you get throat symptoms, you get fever or feel feverish, followed by a cough. Sometimes one is more, sometimes one is less. In this constellation of features, without COPD, one advises people not to see a doctor, use home remedies, steam inhalation, paracetamol, ginger tea, hot chicken soup, stuff like that. For COPD patients, this can end up in an exacerbation, which you treat by increasing the inhalers. If they don't work, you come into hospital. That's where the exacerbations come in. And we can prevent almost 70 to 80% influenza, which is this used to be the most difficult and most serious virus, respiratory virus. And if you take influenza virus vaccines 3 years running, your chances of dying go down by 20%. Dying, I'm not, forget about thing. It is not 100% vaccine. About 70-80% is effective, and the rest have less thing. But it is mandatory in anybody with COPD. It is mandatory in everybody above 65.
Right.
So
Sorry.
no, no,
You
go on.
want to say something else? So I think this vaccination is a very important issue to try and prevent hospitalization. But I think there's been a question which has been on the top of my mind, and I find Dr. Shomit Koshal is asking you that what is the role of high dose steroids in COPD and for how long, taking into consideration that patient may be diabetic?
Let me be very categorical about it. I have stopped using high dose steroids for about 20 years. The scientific literature is very clear that it doesn't help. Prolonged course of modest dose steroids also is bad. It increases mortality if you use it for 6 weeks. And the recommendation is only during an acute exacerbation, you use up to 5 days of modest dose steroids. To put it into perspective, 32 milligrams of methylprednisolone or 40 of prednisolone. Any other higher or longer doses actually increase morbidity and mortality, makes you more likely to uh, die or get admitted or have more symptoms. This is now in all the international guidelines. The gold guidelines specifically state 5 days 40 pred during an exacerbation, nothing else. You stop it after 5 days. So it's very categorical. There's no argument about this.
So, doctors who are watching this, I think this is a very important message from Dr. Sengupta. And I think we need to be aware that using this high dose steroids is not a mere cure all for COPD, even if the patient is sick enough to be admitted. And so, please remember what he said. It's not something that you use very willy nilly. And this is something that you must try and learn in your clinical practice if you aren't already practicing it that way. Dr. Sengupta, we are now running short of time. I'll let you have the last word. What is your message to physicians as well as to patients with COPD?
I think You're going to see everybody. We are going to see, you are going to see COPD patients all the time. You must insist on three things. One is actually preventing the disease progressing or stopping it happening by stopping smoking. Number two is, if you have significant disease, get it assessed, get it treated, get the inhalers in properly by proper, like training and everything. And number three, if you are seriously unwell, please see specialists. There is very good treatment nowadays, and I end by saying that. I would not have imagined 30 years ago that we would be able to treat COPD patients as well as we can do nowadays.
Thank you, Dr. Sengupta, for giving us your time and for giving us this load of such useful information, which I think is going to go down wonderfully with all the viewers of our vlog. So it's good night from East Kolkata Doctors Group. It's good night from me, and it's a good night from Dr. Sumit Sengupta. Stay well, stay fit, stay healthy. Thank you very much.
Thank you. Thank you, Vinay.